Ultrasound should also be used for assessment of gestational age. The crown rump length is the most accurate in the first trimester to assess for gestational age, but as you go on to the second trimester, we use the biparietal diameter, and that should be performed at the level of the thalami and the cavum septum pellucidum. The cerebellar hemispheres should not be visible in the biparietal diameter, and we should measure from the outer edge of the proximal skull to the inner edge of the distal skull, as you can see here in this diagram. The cavum is right up over here, and this is the midline falx, and there's leading echo to leading echo. Now, just recently in 2008, Peter Callan wrote a paper that was very helpful to us in noticing that the cavum has no echoes within it, whereas if you take it a little bit low, you are really in the fornices, and then it is these fornices that tell us that we're a little bit too low in the fetal head in order to call it the accurate biparietal diameter. And why do we care? Because we care because you can have agenesis of the corpus callosum with an absence of the cavum, and that may be a very important sign for an abnormality of the brain. When we look at gestational age, we not only do the BPD, but we also look at the head circumference and measure it at the same level as the BPD around the outer perimeter of the calvarium. And here's another measurement showing the head circumference, and you can see that this head is a little dolichocephalic. It kind of is boat-shaped and looks a little bit flattened in the middle, and that is still a normal appearance to a head. It's just going to have a more accurate head circumference than biparietal diameter. The femur length is the next structure we assess gestational age with, and it's pretty reliable after 14 weeks. It's most accurate when measured with the beam of encination being perpendicular to the shaft as shown in this picture, and excluding the distal femoral diatheses. We also look at the abdominal circumference for assessment of gestational age, measuring at the skin line. It's important to get a true transverse image at the level of the junction of the umbilical vein, portal sinus, and fetal stomach when present. This abdominal circumference is used to estimate fetal weight, and it may allow detection of IUGR and macrosomia, and this is the level we like to take it with the stomach and the hockey stick or the umbilical vein coming in. It's very important to look and see where these calipers are put, particularly in the third trimester, as it's really easy to underestimate the size of the abdomen if you're not careful. Now, in general, we use a variability of dating rule that in the teens, it's within 1 week of variability, in the 20s, it's within 2 weeks, and in the 30s, it's within 3 weeks. But there's a caveat to this that if you have a prior ultrasound, then you should be growing within about a week of your original ultrasound dates. Intrauterine growth restriction, the causes are congenital anomalies, infection, maternal nutrition, maternal hypertension, maternal smoking, and drugs, just to name a few. In general, how do we make this diagnosis? We do serial ultrasound studies. We find a small biparietal diameter or a small abdominal circumference. We look at the head to abdomen ratio, and if that's not correct on the tables, then that's worrisome. We look for oligohydramnios and abnormal Doppler studies. There's two types of intrauterine growth restriction. Number one is symmetrical, where both the head and the body are delayed, which tends to be more frequently in the second trimester, whereas asymmetrical intrauterine growth restriction is caused in the third trimester, and it has head sparing with the body being smaller and the head being more normal. In general, the symmetrical types are much less common, only 25%, and the asymmetrical ones are more common. How do we estimate the fetal weight? We use those parameters, the biparietal diameter, the head circumference, the abdominal circumference, and the femur length. We look at interval measurement changes, and these can be performed every 2 to 4 weeks depending upon what time in gestation it is. We usually do them further apart when we're in the second trimester and closer together in the third trimester. The error may be as high as 15% in estimating the fetal weight. At our institution at the University of California, San Diego, we take 3 measurements of the abdomen circumference in the 3rd trimester if it's an abnormal number or if the patient is diabetic. We do look at the growth curves in order to assess for fetal growth in the 3rd trimester, and these would be fairly normal measurement up on the left, but you look at the abdominal circumference, it's going up above the 95th percentile in the curve on the right. Okay, we also need to look at the maternal anatomy, to look at the uterus, the adnexa, and once again, the presence, location, and size of myomas and adnexal masses. So this is a left ovary that we can see is a normal structure, whereas this is a fibroid that is living in the retroplacental region in the upper left-hand corner in a pregnancy at 19 weeks. We can see this fibroid over here under the placenta as well. When they're retroplacental, they have an increased incidence of abruption when it gets closer to delivery and intrauterine growth restriction. This is kind of interesting fibroid kind of sitting right inside the amniotic fluid. Now the fetus also has to be looked at for an anatomic survey, and this can usually be done after 18 weeks gestational age. There will be technical limitations in some patients that are larger or when the fetus is an unusual presentation, and follow-up may be helpful in those cases. So we're going to go through the fetus from head to foot. When we look at the fetal head and neck, the guidelines tell us we need to look at the cerebellum, the choroid plexus, the cisterna magna, the lateral cerebral ventricles, the midline falx, the cavum septi pellucidum, the upper lip, and the nuchal fold, both of which were added in the 2007 guidelines. So we look over at this picture of the head, and you can see the cavum septum pellucidum. We can see the cisterna magna with the posterior fossa, and you can see the nuchal fold sitting right back here. You measure from the edge of the cranium to the edge of the skin there, and you do need to be at the level of the cavum. The choroid, you need to measure the ventricles from the medial wall to the lateral wall where you see 2 bright echogenic lines. Once again, the cavum septum pellucidum with no central echo within it. The palate is not yet in the guidelines, but it is something we do at the University of California on everyone, and this is the palate with the primary palate here and the secondary palate posteriorly and in the back. The lips, as we said earlier, have been added to the guideline. This is the upper lip, and you can see the 2 nostrils right here of the nose. This would be the lower lip. The nasal bone is not yet in the guidelines, but it is something that is becoming more commonly done, and we do it on all of our patients in our lab for the risk of aneuploidy and Down syndrome specifically. You can see that this is the chin of this fetus. After the face, we go look into the chest, where we look for the 4-chamber view of the heart, and we attempt to evaluate both outflow tracts. The 4-chamber of the heart is here. You can see these diagrams showing the normal axis of the heart, 45 degrees axis when you look at the spine towards the sternum. And you can see the 2 atria, the 2 ventricles, similar in size. The heart occupies about 1/3 the size of the chest. We look for an intact septum and an intact crus, as well as the position of the valves themselves. So we should try to get 1 rib on each side to get a normal 4-chamber. Not always easy to do. You can see here we have a normal 4-chamber and we only have 1 good rib, so it's not always necessary, just can be helpful. There is the crus. You can see that the tricuspid valve is just a tiny bit lower than the mitral valve, which is important. The left outflow tract comes from the left ventricle. That's from the aorta, sweeping along here, and that's very important to look for VSDs as well as malalignment, because if the aorta goes over into both ventricles, then we worry about transposition of the great vessels, truncus, or tetralogy, double outlet right ventricle. This is a picture of the right ventricular outflow tract. We call this the sausage and the egg view. We like that. Radiologists love food. Here is the sausage and here is the egg, and that's the aorta in the middle with the pulmonary artery here with the pulmonic valve coming right out of the right ventricle. You can see the right atrium here with that tricuspid valve, just like in the diagram to the left.